Hey everyone, welcome to the Facebook Live. We've got Steve Wimberly from South Africa, from the Westfield Veterinary Hospital. Hey Steve, how are you doing?
Hi, very good, thanks. Welcome everyone.
We just wait for some people to come online and we can just check to see whether they can hear us all right. Steve, do you want to tell us a little bit about yourself, your background and where you're from? And yeah, you can just tell us a little bit about what you do in the practice.
Right, well, I try to do as little as possible in the practice, but somehow I get sucked in and end up doing a lot. I qualified way back in 1986 and had to do 2 years military service as an army vet, and then I joined Westfield Veterinary Hospital in 1988. And although I've tried to leave a number of times, I've never found anywhere better. So either I have low standards or the place is really great. Anyway, the hospital has grown and grown, and currently we a fully kitted out hospital with 9 vets and about 7 nurses and a full complement of about 65 staff, offering a 24/7 service and a full range of surgical and medical services. And we have 1 physician specialist, and then we have myself and my partner that do most of the surgery. We're not specialists, but we have basically just learned over the last 30 years with doing numerous courses and just teaching ourselves. So between my partner and I, we'll cover, the full range of surgery from spinal to orthopedic to abdominal. And my main interest is over the years, the last 28 years, has been orthopedics and spinal and fracture repairs, lots of that, and lots of cruciates, obviously. And so for 28 years, I've been trying to fix cruciates. And anyone who does surgery on knees in dogs and cats will know that the perfect technique has not yet been invented. And surgeons keep coming up with new techniques. And so I've done all the techniques ranging from, extracapsular repairs using nylon or wire. Even in the 90s, we used wire, and we've used fiber wire, and I've done TPLOs, or should I say TTOs, the Australian version, triple tibial osteotomies. And recently now I'm doing TTAs, tibial tuberosity advancements, and MMPs. But with, like everything with surgery, when it works, it's fantastic. And when it fails, it is awful. And it's the failures that I've lived through, in particular the ones where I've taken a dog with a small limp and turned it into a dog with a massive crippled limp for the rest of its life, or it's even been euthanized, that I've really found hard to live with. And so 5 years ago, thanks to a colleague I worked very closely with, a lady called Jane Fraser, who's our local vet who does acupuncture and homeopathy and Chinese medicine, she suggested I look into prolotherapy. She'd found out about it through the complementary veterinary group she's on, and there were links on YouTube to vets doing prolotherapy in Europe and in the USA. And I watched them, and I was really skeptical about it. Having a surgical bias, I didn't believe you could really get a knee right with anything other than doing surgery. But there's so many cases where you're actually setting yourself up for failure with surgery. So, very overweight animals, very old animals with Cushing's disease, very young, boisterous Dobermans, Bull Terriers, Boxers, where you just know the owner's never going to confine that dog as much as you would like them to. And you just know they're going to bugger their leg up. You can do the most beautiful surgery, and it's going to come back broken in 2 or 3 weeks later. So I started I looked into the prolotherapy, a little bit how the technique would work. I needed to grasp the principle in my mind before doing it. And the principle is really simple. And so it suited a surgeon's brain. There was very little studying to have to be done, and very little facts. It's a very simple idea started by a human medical doctor way back in the 50s, George Hackett. Proliferative therapy is essentially injecting a irritant substance into a damaged piece of tissue, whether it's a ligament or a tendon or a joint capsule, to encourage a inflammatory response more than what is present already in the damaged tissue. So aggravate the inflammation, and the result from that is stimulating fibroblast activity, and then collagen deposition, and then healing. So it's actually quite a different mindset to what we've been drummed into as medical doctors and vets for the last 30 or 40 years, where, damaged tissue, you need rest and anti-inflammatories. But actually what we need is inflammation and movement, obviously controlled movement, but we heal by inflammation rather than by turning the inflammation off. So what I've been doing with these knees then is injecting it's a 50% dextrose solution. Well, it's diluted, actually. It's actually a 25% dextrose solution into the side of the knee in the same plane and direction as if I was going to do an X-cap repair. So from the fibula down to the tibial crest, all the way along the lateral aspect of the knee, picking the periosteum of the bone and injecting the mixture at the same time. And then quite a lot around the joint and into the joint capsule, but very little actually into the joint. And then also inject the medial collateral ligament. So we create an inflammatory reaction basically all the way around the joint, and especially on the lateral retinacular tissue, which becomes inflamed. And then we don't use anti-inflammatories. We use painkillers, Panado, paracetamol, or tramadol, or something else for 2 or 3 days if the animal's sore. But we expressly don't use anti-inflammatories, and we start rehab if the owners can afford it, or if there's rehab available, we start that 5 to 7 days after the injection. So we have inflammation and movement, and then we assess the dog at 4 weeks, and if there's an improvement, we'll repeat it, and again at 8 weeks. Most of the cruciate injuries I'm treating like this have improved enough at 4 weeks for us to allow us to go ahead and do a second one. I don't like to put an animal through an unnecessary procedure nor an unnecessary expense. So I usually video the animals walking at day 1 and then compare at 4 weeks. And if we can see they're visibly improved, walking better, we'll continue. If they're not, we'll reassess our treatment options. And not all of cruciate injuries will respond, just like not all surgery will work. My experience, it seems like out of 120 odd dogs I've done now, it's roughly 65% will be really, really good at basically back to normal at about 4 to 6 months from starting. And that's very, very similar to X-cap repairs. And then about 25% will be virtually 100% normal, but now and then if they overdo it, they'll come up lame for a few steps. And then about 10%, if I've added up right, there will be no improvement whatsoever. Those dogs are just as lame as when you started. And most of those dogs will turn out to have a meniscal tear. And that's the one place where prolotherapy will not work for cruciate disease, is if they have a concurrent meniscal tear. I think that's...
Those cases that you're talking about with those percentages now, are those full ruptures and partial ruptures?
Yes, they're everything from partial to full. So they range from 3 millimeter draw to 8 millimeter draw. And they're all size dogs from 5 kilos to 65 or 70 kilogram bull bulls. It's actually quite interesting. You can't predict the ones that are going to work. You can sort of get a gut feel after doing many, but in the beginning you can't really predict. You just try. You obviously have the owner on board with you, because you can't guarantee an outcome, so you need to explain that up front with them, and you know, I'll reassess with them at 4 weeks, and then at 8 weeks, and then at 12 weeks. And some of them just aren't improving, so we go to surgery. But many more than I initially thought would respond amazingly well. And what's quite interesting is the drawer actually doesn't always go that quickly. So an animal with a 5 to 7 millimeter cranial drawer at 4 weeks will still have that degree of draw at 8 weeks, but will be weight bearing a lot better. And we're not quite sure how that works, but we suspect that one of the effects of the prolotherapy, the actual mixture is if I'll put it out exactly, it's 1 ml of lignocaine, 4 ml of saline or sterile water, and 5 ml of 50% dextrose. So that gives us a 25% dextrose solution with some lignocaine. So what we think may happen, and it's reported in humans as well, once they've had the prolotherapy to their joints, is that it somehow interferes with conduction of nerves and pain. So people report quite a marked reduction in pain after the procedure, and will use their joints more quickly, which is very conducive to healing and getting joint fluid moving and cartilage restoration. So we think the same happens in dogs, because they will weight bear better, but if you palpate their knees, there's still quite a draw there often, and that draw I'm finally finding goes at about 8 to 9 months. When I'm getting them back for other procedures, when I'm seeing these patients back at a year, the draw is gone completely, the knee is fully healed. But it takes a time. And I know anyway with my X-cap surgeries that if I palpate those dogs at 8 weeks or 12 weeks, they're all loose. There's no one in the world that can do an X-cap and not get it loose at 8 to 12 weeks, looser than when you started. If it's not loose, you actually made the suture too tight in the beginning, and the knee wouldn't be able to flex. So what actually happens with the X-caps is they also loosen, but you get the scar tissue from the surgery that eventually forms enough stability for that knee to rehab itself and move forward. So that's an interesting thing. What we've noted is that they weight bear better, but their knees are still quite loose. Now, those dogs, I do warn the people, they're weight bearing better, but they've still got quite a marked cranial draw, that they are at risk for a meniscal tear. So the exercise they do while we doing the prolotherapy over the 8 weeks is leash walking, and we discourage free running and uphill, upstairs, and any kind of crazy running. It's all leash walking, level surfaces or uphill leash walking, because they are at risk for doing a meniscal tear.
I just want to say hi to everyone. We've got a whole lot of new people online. Thanks, guys, for joining us. I'm talking to Steve Wimberly from Westfield Veterinary Hospital in South Africa, and he's chatting about prolotherapy. So for those of you that are joining us now, if you've got any questions, please just put them in the comment section. I'm going to start asking Steve some questions. We've got a whole lot of questions from the Facebook advert. We're just chatting now about those cases on using it in cruciate ruptures. I wanted to ask you a question, Steve. You were chatting about dogs. What about in cats? Have you used it for cruciate ruptures in cats?
Yes, well, I find it works even better in cats for cruciate injuries than it does in dogs. It's phenomenal how quickly they heal. Cats generally heal quicker anyway, being lighter and more nimble. And often they just need one treatment, maybe two at 4 weeks apart, and they're much, much better. And so it's hardly ever will I operate on a cat's knee now. I'll do prolotherapy first. And only if at 8 weeks, if the cat's not really improved, will I go to surgery. But it's not common that they are not improved. They don't tear their menisci as easily as dogs do. Yeah.
Do you need a little bit of water? You're a bit coughing.
Yeah, thanks. Bit of it's not my own urine.
Oh, Ross.
Yeah.
Steve, I wanted to chat about those cases, because I know that some of the dogs that you operate on, while they're under anesthetic, you actually do prolotherapy on the contralateral knee. Can you chat to us a little bit about that?
Yes, that's been a very interesting innovation or idea that came to me. So it's not just that the knees I operate on, but all the prolotherapies I do on a damaged or an injured cruciate, I'll do the normal knee as well on that dog at the same time. So we know that about 50 or 60% of dogs that tear one cruciate will do the other one within a year, something like that. It's a high percentage. The same forces are in play in both knees. So it stands to reason that if they've torn one, they're going to tear the other. The same tibial plateau angles in play, the same potentially degenerative disease process that makes those cruciate ligaments go all yellow and degenerated when you look inside the knee. That same disease is going on in both knees. So a lot of them tear both. So what's been very interesting is it's just an idea that came to me. I do tell the owners that I didn't get muddled up and do the wrong knee first. I do both knees on purpose. What I'm interested in to see is there any benefit in preventing it happening in the normal knee? So for about the last 4 years, I've been doing the normal knees as well, and then waiting for them to come back and waiting to follow up. And at this stage of about 50 normal knees I've done, and actually it's more than that, because because I just narrowed my figures down to 3. I needed some normal knees. I just did 1 treatment, and then we lost the dog. They moved away or whatever. Or I did 2, and then the other knee was so good we never did 3. But I basically just took out the stats where I'd done 3 treatments at 4-week intervals on normal knees, and saw how many of those have come back, and it's only 15% at this stage. And that's, so we still need more numbers and we need longer time, but it seems very encouraging. There will be no evidence really when you palpate that normal knee that you did anything. That knee is not going to be thicker. It's not going to have more fibrous tissue when you palpate it. So it's still, I'm not sure if it's doing anything, but it's been very, very interesting, and I'm continuing to do it and monitor the stats coming back. But it seems quite exciting that I may be having an effect in preventing the normal knee from going, let alone healing the damaged knee. I might be preventing the other one going as well. And the other nice place to use prolotherapy is if you've done an X-cap repair and the dog's gone ballistic and stretched it and it's come up lame at 7 or 8 or 9 weeks post-op. It's been doing brilliantly. And every surgeon who does X-cap repairs will have that heartbreak. And your patient, it stitches out, was walking nicely, and then your heart just sinks when you see it coming down from the parking lot into the practice at 8 weeks and its legs off the ground and it's overdone it and ripped your suture. Now, those animals can rehab really nicely with prolotherapy instead of going back and reoperating, because you've already got a nice thick band of scar tissue there to work with on the lateral retinaculum of the knee. So they really lend themselves to rehabilitating with prolo and rehabilitation exercises and not having to have more surgery, which is a huge relief for the owners as well.
Yeah, that'll be awesome to see, especially those ones that you're doing in the contralateral side. I'd love to get you connected with some other surgeons and get them also to start doing some of these cases, so you can increase your stats, so we can actually have a look and see what it's going to turn out to look like. But I must say, I find it very promising. I've been following you for a few years now, and it just, it seems like it's something that potentially could work. And you never know, maybe in 10 years' time, we will all be doing prolotherapy on the contralateral side. So very interesting.
Maybe. It seems that the other amazing thing is that I've been, as I've been tracking these cases now over a few years, and as they come back for other procedures, I take an X-ray of the knee that I treated with prolo, and we know that all cruciate injuries end up with degenerative joint disease in the knee. And if you do X-cap surgery, you're not going to change that. You might limit the progression of the degenerative joint disease if you do a TPLO surgery or equivalent. But certainly with X-cap surgery, that those stifles are going to look very arthritic on radiographs. And so just out of interest, I've been seeing what do these knees look like after prolotherapy has rehabilitated the knee. And a lot of them do have arthritis as expected, but some have absolutely blown me away. I had a Boerboel, so a 65 kilogram Boerboel, who did both these knees, but at about 8 months apart. And that was that was one that failed. The three on the normal knee failed. But anyway, the first knee he did, which I rehabbed with prolo, at about 18 months, he came back for the other knee. That knee, I x-rayed and I palpated it. You would never ever know he ever had a cruciate injury, and he had a 5 to 7 millimeter cranial draw. There was no DJD on his x-rays whatsoever. There was no cranial draw, and there was hardly any medial buttressing or periarticular fibrosis. That knee was like a normal knee. That just blew me away. So it's I'm not saying that's going to happen with all of them. That's for sure. It's not. But the fact that it even happened with one has blown me away. And then shortly after that, I had a Yorkshire Terrier, very similar. Also did both knees, and also the knee I did first, and that was about 9 months post. No DJD on the x-rays at all. Perfect range of motion. Knee completely normal. So there's something to this. There's an Israeli vet who's done a lot of prolotherapy, and I keep forgetting his name. He's a guru on it. I can get his email address for people afterwards if they want it. And he postulates that the sugar, the dextrose, may be encouraging insulin growth hormone and other factors into the joint and stimulating a disease-modifying process in the joint so that it promotes healing. That's definitely a possibility in my experience.
Sure. So we've chatted now about the cruciate. What about other joints? So what about things like hip dysplasia? Have you ever used it in hip dysplasia?
I started off doing quite a few hips with it, and I have to say it didn't make any difference whatsoever in my experience with hips. Those dogs were no better after prolotherapy in their hips, and no much better in elbows. But where it really has helped me is in shoulder ligament injuries, biceps bursitis, and especially the medial scapulohumeral ligament injuries, where there's really no defined surgery that helps. And no surgical techniques that are you can try, but you generally don't have a great result. But doing Prolo into those shoulders has been fantastic. Those dogs really have improved. And I just don't have the caseload. They're not that common. So it's, the ones I've done have worked, but it's only about 10 or 12. So it's not enough to even know if it's significant. But it is a treatment that I will offer first to a shoulder ligament injury, a dog with a shoulder ligament injury, or a cat, before I do any surgery. And then where it really works well is for hyperextension injuries of the carpus. So instead of traditionally wanting to do a arthrodesis, I will stay away from that at all costs, because although those dogs will wait there, they're never normal again with their range of motion. So I will, if it's not too bad, I will just do prolotherapy once every 3 or 4 weeks into the the damaged tendons, the flexor tendons, and the suspensory structures of the carpus. If it's very bad, I'll put the joint, the carpal joint, in an external fixator for 8 weeks and inject the tendons every 3 weeks with prolotherapy, and then take the X-Fix off, and that's often perfect. Then still got range of motion. You will have a bit of DJD in the joint probably, but they wait there, and the joint hasn't had to be fused. There's no arthrodesis necessary. The other great place is road traffic accidents, MVAs, where you have collateral ligament damage to hock joints, and it's all scraped away, and you would now maybe want to go and stabilize that surgically. You can do that with prolotherapy as well. You can stimulate, as long as you've got some skin and some ligament tissue left, you can stimulate healing of the tendons with prolotherapy instead of doing surgery.
Yeah, awesome. Especially those carpal hyperextension injuries. I mean, those are always they're so tricky to treat, and you just never know what to do with them. And
so what I say to people is that an arthrodesis we can always get to. The animal's got to kind of earn it. I'm going to first try and rehab that leg, and I'm not going to put it in a bandage. The worst thing you can do is put that in a bandage and immobilize it further, and you weaken those ligaments that are already stretched. You weaken them even more. In fact, if for those people, and I've done those a few times in my life where they've had no money whatsoever, I've just said to them, just let that dog carry on walking on its tendon that's sinking, and slowly it will heal by itself, and that often does with doing nothing, but not immobilizing it, because it just weakens it further. Because our instinct is, it looks terrible, let's put a bandage on and hide it, and we don't have to feel better about it. But you actually let them keep walking on it, and slowly those tendons heal themselves. So cats, brilliant with that. Small dogs, brilliant. Bigger dogs, a bit more of a challenge, and that's where the X-Fix might come in to provide a bit more stability while the tendons heal. And then you inject. Yeah.
Thanks, Steve. We've got a question. Daniel asked a question about just chatting about the difference, if you can compare it to platelet-rich plasma injections. And he also wondered what would be better, platelet-rich plasma injections or prolotherapy.
So they're two very different things in my book, and it's not one or the other. You can use both, but what I do is I try and choose the technique I want to use for a damaged joint that I think I'm going to get the best result from. So for cruciate injuries, and ligament injuries, I'll choose Prolo. But for chronic degenerative joint disease in elbows especially, I find PRP really great. Now, I do a very, very simple, primitive form of platelet-rich plasma. Anyone can do in their practice. It requires virtually no equipment. And I'm not saying that this is a great way to do it, but I'm doing it, and I'm finding it helps some animals. So it's very simple. You draw off blood from the jugular, and it's a yellow top tube, and I can't remember the exact anticoagulant, but it's quite important. So afterwards, I'll have to email it to you. And you spin it down 4 minutes at 4,000 revs, and you suck off the supernatant, which gives you about 1 ml. And if you make a drop of that that supernatant and put it on. You don't want any red blood cells in there. You just suck off the serum and the supernatant. If you make a drop of that and put it on a slide and stain it, you'll just see hundreds and hundreds of platelets. Then you know that's the sample you want. And then I don't modify that in any way. I just inject that into the joints. So it's a very simple, quick procedure done under sedation. It's very cheap. And especially for the poor dogs with these chronic elbow dysplasias, I'm finding a lot of them are moving easier after about 2 weeks of doing PRP. But it's fairly short acting in its effect. It seems to last between 2 and 4 months, and then you've got to repeat it. But because I'm doing it so simply, money is not really an object. So the people are keen for me to keep doing it. So that's where I'm using platelet-rich plasma a lot. And I haven't found prolotherapy works at all for elbows and nor hips. You could, in theory, do PRP into arthritic hips, but it's quite tricky to get into the hip joint, excuse me, properly. It's a lot easier to get into the medial compartment of the elbow joint, especially if you do elbow scoping, you know your landmarks well. It's very easy to do an intra-articular injection into an elbow, but it's quite tricky to get one into a hip with any confidence.
That spinning down, is that the same way that you do when you have an ulcer, a corneal ulcer? When you drop, is that the same way you do it?
That's a centrifuge. You just put it in the centrifuge.
Yeah, and then that's the platelets. Is that the same thing that you put into the eyes of corneal?
Yeah. That's serum. Yeah.
Serum
to get the eyes to heal.
Remember that.
Yeah, exactly. Yeah.
Back in my veterinary days when I wasn't doing vet rehab. Awesome.
So
guys,
there's much better ways to do PRP and to buy the right kits and to activate those platelets, but it obviously costs a lot more. So I out of interest just started with doing that because it's simple and easy and cheap.
Guys, if you have any questions, please just post them in the comment section below, and I'll ask them to Steve. Steve, have you done any other animals? So we've talked about dogs and cats. What other animals have you done?
No, luckily I only see dogs and cats. My experience with birds was quite short-lived. I basically had offered two things with bird work. I gave a guarantee that the owners would get the cage back, and then as I printed the computer, as I entered on the computer bird consultation, it printed the sympathy letter at the same time. So I have not done any bird work. I'm just a cats and dog vet at the moment. Used to do some exotics when I was much younger, but rabbits. But no, I haven't done any others. Yeah. And
no self-treatment. Family treatment.
Not with prolotherapy actually, but quite a few other self-treatments. I've been known to aspirate my own knee stifle or knee effusion and take it off to the doctor and tell me what he thinks of the cells.
Awesome. I think that we've answered virtually everyone's questions, so there's no more comments coming through. Guys, if you are watching this as a recording, please, you're welcome to post some questions. I will get Steve to come online and answer them and let him know once you've posted your questions. Steve, thank you so much. Always awesome to talk to you. And we were just chatting earlier. Steve, unfortunately, on Saturday is not going to be able to attend WebCon in the beginning of WebCon.
In the end, yeah.
So for those of you that are attending, it's WebCon, our virtual veterinary rehabilitation conference on Saturday. The Online Pet Health team are working overtime to get everything ready for you guys. We're super excited about it. It's 10 hours of continuing education on neurological rehabilitation. So Steve finishes work at 1 o'clock. So we expect to see you there. 1:30 or 2. Hey, Steve, you better come to the Online Pet Health booth and say hi, hey?
Okay, that's a deal. Okay.
All right, awesome. Thanks, guys. Thanks, everyone, for listening, and thanks, Steve, for your time. See you on Saturday.
Cheers, everyone.
Bye-bye.
Bye.